Hello and welcome everyone. Good afternoon, good morning or good evening from wherever you are joining. I learned that we have registered participants from 26 countries, so quite a global interest, I'm happy to say. And it's my pleasure to welcome you here. My name is Dr. Volker Humbert. I'm Senior Director Medical of the therapeutic area liver and kidney of CytoSorbents. It's my pleasure to have two experts in the setting of liver dysfunction and also the use of hemoadsorption with us today. On the one hand side, we have Professor Ali Canbay from Bochum, Germany. He's head of the Department of Medicine of the University Hospital in Bochum. So a warm welcome. Great to have you here, Ali. Thanks for joining today. And on the other side, we have Dr. Schneeweiß-Gleixner from Vienna in Austria. He is coordinator on the liver ICU of the AKH University Hospital in Vienna. So also to you, a warm welcome. Great to have you here.
Thank you very much.
Yeah. The topic of today's talk, or for the next 60 minutes, is hemoadsorption in ACLF patients, so acute on chronic liver failure patients. What did we learn so far? We learned a lot for sure, and we will hopefully, and you especially, learn quite some nice things today as well. So the idea is that Professor Canbay will start with a bit more general overview on ACLF, its features, its challenges, and also some potential ideas or rationale for the use of hemoadsorption. Before then, Dr. Schneeweiß will present his personal, recently published experiences on the use of hemoadsorption in ACLF patients, also compared to some historical controls. And then we will discuss the implications for today's practice, the best practice, and also other questions. And I would like to encourage you to ask your questions you have, either general questions or direct questions to one or the other speaker. Ideally, you enter those questions in the Q&A part. There's a button at the lower part of the Zoom screen, so where you can then enter your question, and either it will be directly referred to one of the speakers, or as I'm kindly supported by my colleague, Dr. Maria Soledad Taboada-Küper, also a medical doctor, she will then answer one or the other question also in a written manner. And without further ado, I think it's time to start. So let's start with Professor Canbay's overview on ACLF. The stage is yours, Professor Canbay. Thanks a lot.
Thank you very much, Volker, for the kind introduction. So I will start. Okay, so I will going to talk about acute or chronic liver failure, and but I will also touch on acute liver failure, because I think this is very important to understand what means liver failure. So it's the next, just on my conflict of interest here, and then just talk first about liver failure. We do have acute liver failure based on you have cirrhosis, and in some cases you have liver failure without any signs of liver cirrhosis. This was a liver from a young lady. She took acetaminophen because her friend left her, and so that was the reason why she took 50 tablets, pills inside, and this was the reason that she got transplanted. This is a liver with liver cirrhosis, and what is going to happening in this case, the cells, dies by necrosis, apoptosis, necroptosis. This is not the case now, but then you have elevated liver enzyme, AST/ALT values, and then of course you have elevated bile acids, and then you have impairment of coagulation, and of course hepatic encephalopathy. So this was a definition what we made in 2011, published. The first definition is just to talk about acute liver failure. It means without any previous liver disease. This could be a hyperacute, acute, and subacute. And then you have acute and chronic. That means you have liver disease, but without signs of cirrhosis. Usually, you have NAFLD, what is named now MAFLD, metabolic associated fatty liver disease, or alcohol liver disease, viral hepatitis, and then you have another drug which leads to liver failure. And the third group is what we think, and this is what EASL actually also named acute on cirrhosis liver failure. But this is, I think, different then in this kind of patient, you have cirrhosis, which means the capacity for regeneration is very low. In this kind of patients, you have splenomegaly, you have already varices, and of course, thrombocytopenia. So the canonic study presented the first evidence with ACLF. This means actually acute on cirrhosis liver failure. It's a syndrome characterized by acute decompensation of a chronic liver disease. It means chronic cirrhosis with organ failures and high short-term mortality, 28-day mortality, about 15%. So what we did, we published a paper recently. We look for the patient with acute liver failure and versus acute on chronic liver failure based on our definition in Germany. We initially checked for 130 patients and then looked for them more closer. And we had difference became apparent, suggesting that liver injury may have been presented with our previous cirrhosis, thus leading to the diagnosis of acute or chronic liver failure. So if you compared acute liver failure, the real acute liver failure, you see that they do have higher ALT values, of course, and AST values compared to the acute or chronic liver failure. Mainly of these patients, the reason was they have a diabetes, they have the fatty liver disease, but not cirrhosis. And even in this case of patients, we do have any differences. So let's talk about how we were gonna approach. If we get patients, we check, do we have acute on chronic condition? Do we have already cirrhosis, or it is just only, based on a fatty liver without any signs of liver cirrhosis, or is this a real acute liver failure without any signs of cirrhosis and fibrosis? So then check the prognosis, look for etiology, course of hepatic encephalopathy, what about lactate, and what about transaminase levels and MELD, KKC, and look, do we should transfer the patient to the liver transplant center, and then maybe high urgency listing. But of course, we do have exclusion criteria. Do they have already a tumor or like sepsis or multi-organ failure? They will not get transplanted. But why is it so important to understand what means liver failure? This is a picture which shows that this is a real acute liver failure. So, I showed the picture of this young lady with a liver failure, acute liver failure. She took paracetamol or acetaminophen, and then you lost so many liver cells that the liver functionality was down, and so she couldn't recover. Then you have the acute on chronic with fatty liver, and you have to took drugs, and then the capacity is, of course, not good as acute liver failure, but better than acute on cirrhosis liver failure. Here you can see all these pictures. So this is what we recommend. Check with patient with acute liver failure, check the coagulopathy, jaundice, high transaminase, hepatic encephalopathy. What is the cause identification, then transfer to the hepatology center, liver transplant center with interdisciplinary ICE unit, and look for the therapy, or even you have checked the clinical assessment for prognostic scores like KKC, Kinkalch criteria, Clichy criteria, MELD, or cell death, and even thyroid hormones can be prognostic relevant. And then look if you cannot do, checks etiology is unclear. Maybe you can do a mini laparoscopy and look for the biopsy, and in this case, then you can decide for liver transplantation or not. So these are the clinical EASL clinical practice guidelines published in GHEP 2023, and then what it means is that the progression of cirrhosis. The patient has time to go from cirrhosis as around 10 years for decompensation, and then in ACLF, you have in hospital admission around 30%, and then of course, if you have a higher ACLF decompensation, then its mortality is more than 40% in this kind of patients. This is a very dangerous condition. So European Association of Studies of Liver Disease, and then the CLIF consortium, which means that your brain with hepatic encephalopathy, and you have respiration impairment, circulation impairment, you need vasopressors, and your liver is impaired with high levels of bilirubin, high levels of bile acids, and then the impairment of the coagulation and acute kidney injury. And of course, you have it, which is also associated with acute cirrhosis, liver failure. You have also cirrhotic cardiomyopathy. You have a systemic inflammation with immune deficiency. As you know, liver is playing an important role in immune system. And then adrenal insufficiency. We have a dysfunction of the epithelial barrier and gut. And then we have bacterial translocation. And of course, for long term, this patient develop sarcopenia and frailty. And this is very important to understand what means acute and chronic liver failure. So the pathogenesis, usually the patient has cirrhosis with portal hypertension, which is associated with bacterial translocation, with bacterial infection. And then, of course, we have systemic inflammation. Usually, patients with alcohol hepatitis, they do have, impairment of the barrier in this patients. So then you have ACLF or organ failure in these cases. So definition of EASL was this canonic study was prospective, multi-center from February 2011 to September 2011. Patient with liver cirrhosis and hepatic decompensation, that means ascites, hepatic encephalopathy, GI hemorrhage, and then differentiation between ACLF with organ failure and without organ failure. You can see, go back, you can see here liver, kidney, what I actually showed you, and then also impairment of the respiratory system. So that we have different definitions, which makes really sphere to understand what means, the definition of EASL or North American Consortium and of Chinese group and even APASL. They have a different, definition. But I think the best definition is the definition from APASL, which is really differentiate between what we actually did in Germany. We have liver failure, acute and chronic liver with pre-existing liver disease, but without signs of cirrhosis. And then the third group is acute and cirrhosis with clear definition of cirrhosis. But this is what we should discuss maybe later. So we have this ACLF grade. As you can see, we have of course, in the survival, no ACLF, much better survival. ACLF was 1, that means 1 organ failure with kidney failure, 2 organ failures, and then 3 organ failures. Of course, the probability for the survival is, of course, very low. So the stage of decompensated cirrhosis, we do have, and this kind of patient, severe inflammation, ACLF with 3 months, mortality around 54% for 3 months and 67% for 1 year. And then high degree of portal hypertension with readmission and mortality, mortality around 21% for 3 months and 26% for 1 year, and no readmission with 3 months, mortality only 10% for 1 year. And this is very important to understand what means the decompensated cirrhosis. So To understand what means systemic inflammation in cirrhosis, if you look, this is a very nice work from Jonel Trubitska from Münster, Germany, and he showed actually checked for the inflammation. If you see a patient with no ACLF, look for the inflammation markers like IL-10, IL-6, and then also the other MCP1 and interferon gamma, TNF-alpha is highly elevated in this kind of patient, which means that you have immune paralysis, and then at the same time the liver function is not good as should be. So and then to progression to complication in Germany, as you see, it depends on started with here data from also from Trubitska's group, as they show from 2006 2018. And you see that the portal thrombosis, hepatic encephalopathy, infection, ascites, hepatorenal syndrome, hepatocellular carcinoma are elevating, there is a progression in this kind of patients, or they need, of course, a liver transplantation. So the therapy triggers the decomposition of ACLF, and then in some cases, like severe alcohol hepatitis, a bacterial infection, hemorrhagic shock, and encephalopathy. They are, triggers for decompensation, or is associated with decompensation. And then there was a publication also showed that the early tips improved survival in this kind of patients. So then the next is the treatment with antibiotic treatment is important, and you have to do it as soon as possible. Then you can see that the mortality rate in this kind of patient is lower if you start with an adequate antibiotic therapy in coverage of multi-resistant pathogens. And this is very important to start as early as possible in this kind of patients. At the same time, look for the patient with severe alcohol hepatitis. These are the, this bar shows you participating by severe alcohol hepatitis, and then repeated other causes. And you see that these patients have every 2 months severe alcohol hepatitis in this case. And this is very important to understand how we should manage this kind of patients. Usually we are starting in some cases, but I'm not happy with starting with prednisolone in this kind of patient. Look for the Lille score at 7 days, and then is Lille score lower, then you can use prednisone for 28 days. But I'm not really convinced about this. Why I'm not convinced? Usually if you treat this kind of patient with prednisolone, they do develop sepsis and they die. And in Germany, we are not allowed to transplant patients with active alcohol abuses. So liver transplantation, ACLF, and as you see, early transplantation, this kind of patient, the survival rates are very, very good, even in different stage of acute and chronic liver failure, ACLF stages is still very, very good in transplantations. So how to start the presence of any grade of ACLF, and then look for the general condition as the patients have do malignancies. The same was acute liver failure. Do they have comorbidity and others? Then if yes, then standard of care. No, then look for the alcoholism. At least, they should be absent for at least for 6 months in Germany. Yes, then you can special program. No, then you have to check how is grade, and in some cases, then we are losing patients because of, like sepsis or liver failure in patient with alcohol hepatitis. So we do have an impairment of detoxification of in leading to organ failure. As you can see, you know, as I showed you, you have higher bilirubin values, you have high bile acids, and then you develop jaundice, pruritus, and then this kind of patients have poor response to vasopressor therapy because they have acute kidney injury. Mortality is highly high in this in septic patient, and of course in ECMO patients. And they are on ECMO, they have high mortality rates. And you see on these pictures, it's bile cast, nephropathy, kidney injury with liver failure. So can we help recover? Can we help liver for recovery? Maybe yes. In the Fulminant is diagnosed liver transplantation. If, you know, as I showed you, the picture where the, you know, the recovery is not possible because they do, or they did lose many cells, so they cannot recover it. But there's some liver support devices. Maybe they can complete recovery to baseline in ACLF or ALF, transplant patient, you know, bridging so transplant, reduce inflammation, preserve needed immune response, improvement hepatic encephalopathy, and improvement organ functions, and even detoxification using these support devices. So rationale for hemoadsorption in liver failure, of course, the next talk will about the hemoadsorption. The real good things actually, that's the binding of hydrophobic toxins in whole body, removing excessive levels of inflammatory mediators, as I showed you with, you know, also cytokines, independent from albumin and plasma therapies, was very important, combinable with other organ support therapies, and can be started prior to acute kidney injury onset. So this, my conclusion, acute and chronic liver failure is defined as an acute decompensation of liver cirrhosis, not on a chronic liver failure, with development of organ failure and high short-term mortality due to massive systemic inflammation. And usually you can also use statins and early and adequate antibiotic therapy prevent ACLF. Treatment of the precipitating factors can have favorable influence on the course of disease, and hemoadsorption in ACLF may be beneficial. And early liver transplantation is the only curative therapy. Liver replacement process can bridge the gap until then. And so I want to close my talk. Thank you for your attention, and maybe we can discuss later on this. Thank you very much.
Yeah, thanks a lot, Ali. Very nice overview. I have to say I still struggle a bit with the different definitions of acute and chronic liver failure coming from different parts of the world, but you made it quite clear, and also pointing out some at least potential rationale for hemoadsorption in the setting. So let's now see what the practical use has brought. Dr. Schneeweiß, as I said, will present his experiences. They were also recently published in scientific reports, the use of CytoSorb in 21 ACLF patients, but I don't want to share more details now. This is up to Matthias. So the stage is yours, Matthias. Thank you.
Yeah, thank you very much for the kind introduction. I'm very humbled to present here our experience with the CytoSorb adsorber for acute and chronic liver failure. And just a short introduction, the most of it was already covered in the previous talk, but just to give a little bit, to build up the context now for the experience we had with the CytoSorb adsorber. The ACLF, as we already heard, is a syndrome in patients with acutely decompensated cirrhosis, and it is associated with an intense systemic inflammation. And this systemic inflammation is mainly caused by so-called precipitating events, pro-inflammatory events, mainly inflammation, infection, hemorrhagic shock, etc., which cause this inflammation and then leads to a single or multi-organ failure, and consequently results in high short-term mortality, as we already saw in this figure, where the ACLF grading results in higher mortality rates, as you can see here. So the current therapy standards for ACLF are mainly targeting the precipitating events or causative events like infections with antibiotics, to endoscopy for hemorrhage, specific therapy for specific hepatitis causes. And we also have in the intensive care unit some supportive measures, supportive therapies, for instance, ammonia control, vasoconstrictors for hypotonia, renal replacement therapy in case of hepatic encephalopathy, but also in case of acute kidney failure. Over the last, I think, 30 years now, science was eager to develop some kind of extracorporeal liver support. If you remember, the Mars system was one of the first, the Prometheus, ELAT, etc. But all of these extracorporeal liver support systems really failed to show any benefit concerning the survival, although some surrogate parameters improved during their therapy. But I think the main problem with all these Mars Prometheus systems was that they were extremely complicated to use and required a high amount of education to use them safely. So what's the rationale for using the CytoSorb? As I already mentioned, ACLF is a syndrome which is associated with a high state of pro-inflammatory response, as indicated by high levels of cytokines, as you can see also in the left figure, where they compared the cytokine levels and other levels of inflammatory parameters in ACLF patients compared to compensated and decompensated cirrhosis. And as we can see is that the pro-inflammation is much higher in ACLF patients compared to the other two cohorts. The second thing is that we always want, during a liver failure or acute and chronic liver failure, to hinder that the body is more and more intoxicated with endogenous toxins. And by supporting the detoxification with our liver support system, in this case with the CytoSorb, I think we can both by also hindering or dampening the systemic inflammation, make the regeneration of the body or the healing process of the body even better. And we can see here by this figure what the CytoSorb adsorber is capable of adsorbing from the blood, all in front the pro-inflammatory parameters, but also all the metabolic products which accumulate during liver failure, especially bilirubin, bile acids, and ammonia. So I'm very proud that what started in 2017 with the first use of the CytoSorb adsorber in a patient with acute liver failure, and we then systematically used the CytoSorb in our patients with ACLF. We were now able at the beginning of this year to summarize all the data and publish it in the top journal scientific reports. And for the next 10 to 15 minutes, I will show you the results of our experience concerning this patient population. This is just a short overview of the design of our study. It's a retrospective observational study, including 21 patients with acute and chronic liver failure who were admitted to our ICU between 2017 and 2023. And they were all treated with the CytoSorb adsorber. And all patients, of course, had an indication for a hemodialysis to include the CytoSorb adsorber. What we did with this patient population in our study is we firstly focused on the clinical outcome parameters, which included ICU outcome and the development of diverse ICU-specific therapies. And then we focused on the development of various laboratory parameters during the course of the CytoSorb therapy, meaning that we controlled our laboratory parameters 24 hours after the start of the CytoSorb application and after a whole circle of CytoSorb therapy was conducted in the patient. And we here focus on liver chemistries, also including metabolites accumulating during liver failure, but also inflammatory parameters and coagulation parameters. The last one, the coagulation parameters, mainly as an indicator for side effects. The CytoSorb per se was used always in the pre-filter position when we did the dialysis. We changed the CytoSorb every 8 to 24 hours, depending on how high the laboratory values were. This was always an individual decision of the treating physicians at the ICU. In total, we used 122 CytoSorbs in these 21 patients, a median of 4 CytoSorb cartridges for every patient. The CytoSorb therapy was always in addition to the full supportive therapy according to EASL guidelines, and the CytoSorb application was started as soon as the dialysis cycle hung on the patient. And as I already mentioned, all patients had the indication for hemodialysis. This was either acute kidney injury, hyperammonia, or fluid and acid-base disturbances. Just a short note to how we treat our liver patients concerning the anticoagulation during an extracorporeal circuit. We avoid heparin due to the high risk of bleeding events. Our first choice is always citrate anticoagulation, but in liver failure patients, we have to take care about the citrate accumulation, which is indicated by increasing lactate levels and a disturbed calcium balance. As soon as we had signs of citrate accumulation in our ACLF patients, we turned off the citrate and switched to an alternative, which in our cases was antithrombin 3, which we substituted in order to increase the AT3 activity by 20 to 30%. And we already had very good experience with this approach, so that we don't have any coagulation during the extracorporeal circuit. So these are the basic characteristics of our 21 patients, in total 21. We had 3 female patients and 18 male patients. The etiology of the chronic liver disease was mainly alcohol-driven, but we also have some chronic other liver diseases like the autoimmune hepatitis or primary biliary cirrhosis. The precipitating event for ACLF was infection and bleeding, which is in accordance with the canonic data. And as you already see, is that the survival rate of our patient populations is rather low. Only 5 patients survived the stay at our ICU, meaning that we have a survival rate or ICU survival rate of approximately 24%. And the reason behind this is actually very clear, because we included a very, very sick patient population indicated by a high ACLF grade score of 3, meaning that we have a multi-organ failure of 3 or more organ systems. The Glyph ACLF score also is very high with 67. And as we can see here in the table, the ICU-specific therapies like vasopressors, mechanical invasive and ventilation was also used in a high percentage of patients. So only 1 patient didn't have any vasopressors, and more than 58% of our patient population got intubated and required a mechanical invasive ventilation. Just to show you a short overview of how the course of this patient, the individual course of disease of this patient was during the ICU from us. I also covered here in the red circles the patients during the therapy with CytoSorb, the ACLF grade decreased. So we also have here a clinical response in accordance with all the supportive therapies we gave these patients. In the next steps, we evaluated the changes or the development or the changes of the laboratory parameters during CytoSorb application. So here we have the changes in the liver chemistries or the hepatic parameters on the left-hand side after 24 hours of CytoSorb therapy, and on the right-hand side after the whole CytoSorb application or whole CytoSorb therapy. And what we found is that already after 24 hours, the CytoSorb adsorber had a significant effect on bilirubin levels, meaning that we could find a significant decrease in bilirubin levels after 24 hours. And this decrease was more pronounced even after the whole CytoSorb therapy in all patients. We are not quite sure why after the 24 hours the GGT was falling, but we are currently making some investigations what this means for the future. In the next step, we also investigated the inflammatory parameters, if there were any changes or significant changes. And what we found is that the conventional inflammatory parameters, including the white blood count and the CRP, didn't show any dynamics in any direction. However, the more specific and more fast-acting pro-inflammatory cytokines like procalcitonin and interleukin-6 showed some very significant changes, meaning that they decreased after the use of the CytoSorb adsorber. So for procalcitonin already after 24 hours, and for procalcitonin and interleukin-6 after the whole CytoSorb therapy, meaning that we have here an effect on pro-inflammation in our ACLF patient population. We then also looked at other parameters which are important for our liver patients, meaning here the platelet count, but also the coagulation parameters. Platelet count was used also to detect known side effects of CytoSorb therapy, because we know that the CytoSorb leads to a decrease in the platelet counts also in septic patients. And this was also observed in our ACLF patient population, that the platelets decreased significantly after 24 hours and after the whole CytoSorb therapy. And we also found that the coagulation parameters got worse. However, this may also be an indicator for disease progression. As you remember, all of our patients had ACLF grade 2 and the survival rates were already bad, but we will cover this shortly. With this slide, I just wanted to show you an exemplary course of disease of an ACLF patient after hemorrhagic shock who had extremely high pro-inflammatory parameters, here indicated by very high interleukin-6 levels of more than 50,000. This patient also required very high doses of catecholamines, here with noradrenaline and vasopressin. This patient immediately received therapy with hemodialysis, including the CytoSorb, which was changed every 12 hours. And as we can see here in this upper right-hand slide, is that after 48 hours, the pro-inflammatory parameters, as indicated by interleukin-6, decreased significantly in this patient. This was accompanied by also decreasing catecholamine requirements in this patient. The reason why I have this photo here of a used CytoSorb filter where we washed out the blood and the new CytoSorb filter is that you really can see how effectively the CytoSorb adsorber picks out the bilirubin out of the blood, which we can also see in this graph where the bilirubin levels significantly decreased in these patients upon CytoSorb treatment. So to summarize the lab values or the changes in lab values we observed is that after 24 hours, we had a significant decrease in pro-inflammatory parameters as indicated by procalcitonin. but also of metabolites accumulating during liver failure, as indicated by decreasing bilirubin levels. We also found a significant decrease in platelets. But more important, after the whole CytoSorb therapy, there was also a significant decrease in pro-inflammatory parameters indicated by interleukin-6 and procalcitonin. Bilirubin decreased further, even further than after 24 hours, and platelet counts and fibrinogen levels also decreased. We then had a more insight and comparison between survivors and non-survivors, and what we found is that the decrease in interleukin, procalcitonin, and bilirubin level was even more pronounced in our survivor patients compared to our non-survivor patients, although due to the small patient populations, we couldn't have any statistical significance, but the trend was here. So one might also argue that without a control group, these changes in laboratory values might only be due to the hemodialysis itself and not the CytoSorb adsorber. Therefore, we also included a small control group of ACLF patients only receiving hemodialysis without hemoabsorption with CytoSorb. I have to state this control group is not matched with our CytoSorb cohort. However, it beautifully shows that the hemodialysis alone does not have any effect on the decrease of the bilirubin levels as we have it with the CytoSorb. And what I also want to state is that I first told you that the platelet levels decreased, and fibrinogen levels decreased upon CytoSorb treatment, but we had also had similar decreases only using the hemodialysis, which is indicative that these changes were due to disease progression and not as a side effect of the therapy we conducted by the patients. To conclude our data, the application of CytoSorb was indeed associated in our patient population with the reduction of laboratory parameters indicating liver damage and liver dysfunction, but also pro-inflammation. The application of CytoSorb reduced the systemic inflammation, as I already said, and indicated by interleukin-6 and procalcitonin levels. These changes supported the recovery, at least the short-term recovery of these patients, as indicated by the achievement of hemodynamic stability. So if renal replacement therapy is needed in this patient population, the application of CytoSorb adsorber is easy, feasible, and does not represent any risk for the patient, as I already mentioned. Except for the decrease in the platelet count, we did not see any side effects of the CytoSorb therapy in this patient population. At least no side effect which was directly associated with the CytoSorb therapy. And I think one of the most important factors of this sentence is that the CytoSorb application is very, very easy and can be done outside of any university facility, as you only have to include the CytoSorb cartridge into an already standing dialysis cycle, which doesn't need very much education. And yeah, it's very feasible. However, we still need further prospective studies in order to clarify the real benefit of CytoSorb in this patient population of acute and chronic liver failure patients. Our data are not without limitations, and I think beside the retrospective design of our data, one of the main limitations is that we included only a very, very sick patient populations, as indicated by the various ICU-specific scoring systems like the SAPS-2, the SOFA, or the CLIF ACLF score. So overall, the predicted mortality of our patients was over 80%, and our observed mortality with 76% is nearly the same. So we didn't have any benefit here. This means that all patients presented with multi-organ failure already at the time of admission, where more than three or more organ systems already failed in the patient. So despite the benefits of the CytoSorb therapy, meaning the decreased inflammation and decreased catecholamine requirements, the patients mostly died because of refractory shock. So we were not able to return or to recover the patient in this regard. So the second conclusion I draw from our data and also from our limitations is that an earlier treatment of ACLF patients, maybe ACLF grade 1 or grade 2 with CytoSorb, may hinder disease progression and consequently death by refractory multi-organ failure. So I think with ACLF grade 2, maybe the point of no return was here, and we weren't able to recover our patients. But maybe if we are earlier with the treatment, we have more benefits in this patient population. And with this last slide, I would like to thank you for your attention.
Yeah, thank you very much, Matthias. A very nice presentation. Also, congratulations for having achieved to present those data in such a highly ranked journal. So, as you said towards the end, or as the title of today's webinar is, what did we learn so far? What was your learning? You suggested that maybe an earlier start could provide a better outcome in the end, as they're not that sick, not that moribund as some of those patients apparently were. So have you changed anything in the meanwhile, or have you tried already a slightly earlier start in one or the other patient?
Yes, we already did indeed. So we are currently working on some SOPs in our clinics that patients with liver cirrhosis get to the ICU earlier in order to prevent this multi-organ failure at the time of admission. So this is something we investigated over the course of the last, I think now, not only with the CytoSorb, but also with all liver cirrhosis patients we had over the last 20 years. And I think the earlier you get these patients to the ICU and give them an optimal treatment and organ support, you will cover a better regeneration of these patients, instead of you have a multi-organ failure where not only in cirrhotic patients, but also in septic patients, the outcome is very bad. And most often you are not able to get a regeneration of the organ function.
Yeah, now this is supported also from other data and other fields. Generally, the earlier, the better, also supported, I think, by pathophysiology. What's your approach, Ali, in your hospital? When do you initiate such a therapy? What are your criteria, also in regard to timing, but also maybe in regard to other parameters or so?
I totally agree with Matthias. I think we should start much earlier with the therapy, and this is an excellent tool. We have a lot of patients with, alcohol hepatitis induced ACLF, and it's, as I mentioned before, it's not a good therapy with prednisolone. I don't like it because I lost many patients on sepsis. But this is the reason why we should start earlier and to prevent, ongoing liver progression or disease. And therefore, I think if we can start earlier, then the mortality rate in this kind of patients will be much lower. I'm quite sure that is the best way to do that, because if you start in the end of the progression of the liver disease, you have bad conditions, then the survival in this patient, even you are using CytoSorb, is low. So that means that we have to start much earlier. It's the same with the tips, actually. What I mentioned before, the mortality rate is better if we start much earlier with tips. And the same is actually with CytoSorb. We should start earlier.
Okay, now we have a first question. I was about to encourage people, but there's one question from Juan Carlos Enrique. How would you compare the therapy with others like high volume TPA? maybe you start, Ali, or Matthias. Both of you are, of course, addressed. It's not directly to one of you, but
so maybe if I start,
okay.
Currently we are waiting for the results of the Apache study, which investigates the effects of total plasma exchange in ACLF patients. I think the results in acute liver failure, which we know from the Larsen et al. Study 2016, are quite promising, but we have to wait. I mean, total plasma exchange is also a more complex therapy, I would say, and it's not that easy to use in like the CytoSorb application. However, as far as the data are not here, I'm not quite sure if it's the right approach to give it to our ACLF patients.
Not at all. Maybe I can also do some, comments on this. The plasma exchange, the whole plasma exchange in acute liver failure, I do not agree with this, to be honest, because I think, it depends on the etiology of the liver failure, in some cases. So I think in some cases, and even in acute liver failure, paracetamol or acetaminophen or toxic, maybe this could be, could work, but not in all of the, etiologies you can use plasma exchange, not at all. But I think the best way, and it's very expensive too. Yeah. So we have to also discuss this issue too.
Yeah. Okay. Thank you. What are, I mean, we focus on ACLF, but also you, Ali, started with acute liver failure, generally asking what are other indications for you in the setting, of course, liver dysfunction, for hemoadsorption with CytoSorb?
I think maybe we have to do some studies and in acute liver failure too, but so what is CytoSorb doing actually? They're taking bilirubin, toxic, stuff, and also pro-inflammatory cytokines, which is very important in some case. In some issues, if you have acute liver failure, maybe this is important, bile acids. So we have to look, bile acids are needed for the liver regeneration. So in some cases, you cannot use, or you shouldn't use CytoSorb. But I think the best way to use CytoSorb in acute or chronic liver failure. And in some cases, like paracetamol, even in these cases, you can use also in acute liver failure. But it depends on the etiology. This is the reason why I'm saying, I saw many patients with liver failure, and they have different etiologies. Autoimmune-induced liver failure is different than, bacterial or also, of course, drug toxicity. It's very different. Maybe in drug toxicity, CytoSorb will going to work much better in acute liver failure. Yeah.
No, definitely. It has to be individualized for sure. Yeah. So patients
depends on the etiology. I think you can use it. Yeah.
Any other indications you have in Vienna for? Yeah.
Bile acids is a very good point, because we already have now the experience with chronic or with pruritus, which doesn't respond to the conventional therapy we have upon patients with primary sclerosing cholangitis, etc. So we already used the CytoSorb in this, of course, off-label indication in this patient population. I think we have 4 patients with chronic and therapy refractory pruritus, where we used the CytoSorb, changing it every 12 hours for a total of 72 hours. And we had a very, very good response concerning the pruritus. So I think maybe in this indication of therapy refractory pruritus, there is also a good potential here.
I totally agree with you. And maybe also in secondary sclerosing cholangitis and also in PBC too. We have also in PBC patients, pruritus, which you cannot, even treat them with drugs. Then you can use CytoSorb. So in these cases, maybe CytoSorb is much better than, other drugs, for example.
Oh, okay, thanks for your. By the way, can you measure easily bile acids in your hospital on a routine base? Yeah.
Yes, we can measure in our clinic.
Okay, in Vienna as well, I suppose, or at the AKH?
Yeah, only during the weeks.
Of course.
Yeah, we can the total bile acid we can measure, but not the sub bile acid.
Okay, yeah.
But it's not important actually. But
No.
Bile acids, you know, in this case of acute liver failure, acute and chronic liver failure, doesn't matter, I think, and pruritus, you're taking this bile acid out, and this is good.
Yeah, there was also a quite recent publication from Christina Scharf from Munich, who can measure bile acids quite individually. So she can, I think, measure a bunch of 8 or 9 bile acids. And she was showing quite a acceptable correlation between bilirubin levels and bile acids in those cholestatic liver dysfunction patients. So that maybe the bilirubin can somehow serve as a parameter to get an idea about the bile acids levels. Also during CytoSorb therapy, she could show an even better correlation with the reduction. So maybe this is an approach for those who can't measure bile acids that easily, that this works. So then one more question, Jens, from Serena Jaw. I hope I have pronounced it the right way. If not, I'm sorry. Can you compare the therapy with Mars?
That's actually a very good question. And there's also one study published, I think, 1 or 2 years ago, where they compared the therapy with Mars and CytoSorb. And what we see is that this, at least on the bilirubin level, the CytoSorb is much more efficient in decreasing the bilirubin levels compared to the Mars therapy. And I think what's also very, very important, that the Mars therapy is extremely complicated to use, and you still need a lot of time to accomplish a Mars therapy compared to CytoSorb.
Thank you. Any further thoughts on this, Ali, or more or less?
Oh, actually, this is true. You know, there was a study that Matthias mentioned, and it seems to be that CytoSorb is much better in eliminating bilirubin levels. But I showed you also, you know, in one of the slides, that if you not eliminate bilirubin, which may be very toxic to other organs too. So that's the reason why, if you have high levels of bilirubin, then you should, of course, maybe use CytoSorb in this case.
Okay. Yeah. Seems there are not any other questions. So I think we're approaching the end. So thank you very much for your very nice presentations, all the discussion we had. There's still, of course, a couple of open questions, but I think coming back to the title, what have we learned so far? We have learned quite some things. It seems to be a promising therapy with quite some potential. Of course, patient selection, timing, dosing will remain very important, as in every other indication. In this regard also, I think a good remark from you, Matthias, to change the adsorber early in those patients, not only after 24 hours. If you looked at the adsorber after using a bilirubin patient or a liver patient, you see the workload the bilirubin and the bile acids provide for such an adsorber. So an earlier change, especially in the initial phase or in very highly elevated concentrations, is definitely recommended after 8 to 12 hours. So that's also important. And of course, one or the other open question will be answered in upcoming projects and studies. So thanks all who joined. I hope you learned interesting aspects as well. The liver and kidney therapeutic area has another very interesting field of use, which is rhabdomyolysis. And on that, we will have a dedicated webinar on the 23rd of October. I think the information were already put in the chat by my colleague Attila. So there's a webinar on rhabdomyolysis, focusing on a recent consensus. There was a hemoadsorption in rhabdomyolysis task force led by Louis Forney, which concluded or included overall 19 international experts, and they brought up quite some nice recommendations. They will be presented and discussed in this webinar. So if you're free to join, you're more than welcome. Those who couldn't join this webinar today, so if you have colleagues who wanted to join but didn't make it for one or the other reason, there will be a recording available which we will share with you in the coming days. So there's also a way to look at this webinar at a later stage to learn from what was presented today. So thanks again to you, Ali and Matthias, for providing your nice presentations and the input to the discussions, and all the others. Thanks for joining, and have a nice rest of the day, and hope to see you soon. Thank you.
Thank you very much.